Okay, in this video I'm going to go over questions that were submitted for part 2 of the mood disorders course. Okay, there are encouraging results in the medical literature on the use of hallucinogens such as psilocybin and the alleviation of major depressive disorders, OCD, anxiety, PTSD, addiction, smoking, etc. Psilocybin appears to dampen neuroinflammation. Do you have a hypothesis of which neurological mechanisms are being influenced by such agents? I don't have any experience using hallucinogens. I know there's some potential applications for it. So it's just not my area of training. It's not within my scope of practice. So I don't have a good way to answer your question. I'm sorry. Could you explain potential reasons why a person with PTSD who also has MTH4 abnormality would have brain fog and fatigue after taking liposomal glutathione or IV glutathione? There's just some people that are not going to do well with glutathione for various reasons, just like any other nutraceutical. Some people have issues with sulfur. Lots of theories why people have issues with sulfur. But at the end of the day, I don't think the MTHFR has anything to do with it. About 25% of the population have MTHFR polymorphisms, but very few people have adverse reactions to glutathione. So there's something impacting, theoretically there's impacting the sulfur metabolism, and it's not specific to PTSD and it's not specific to MTHFR. So I really can't give you a detailed explanation for it, but I can tell you that it's not uncommon to see with all different types of patients unrelated to MTHFR and PTSD. Many people with lowered mitochondrial thresholds appear to do well with electrolyte supplementations. Is this due to impaired sodium-potassium balances? It's possible. It's hard to say. I don't notice patients with lowered mitochondrial thresholds doing better with electrolyte supplementations. I just don't see that. I only see, when people have mitochondrial electrolyte, like mitochondria that's not able to produce ATP and get close to threshold, I don't see electrolytes make any difference in that. So maybe we're thinking of different things, but if someone actually has electrolyte imbalances, for sure it can seem to make a difference. You're not going to impact the sodium-potassium pump with electrolyte supplements. So if someone has mitochondrial impairment and their neurons aren't making enough ATP, the problem is they can't push. When they get depolarization and have sodium influx their cells, they don't have the ATP to push the sodium-potassium out. So that sodium is in the cell. No matter what type of potassium or sodium or electrolyte supplement you take, you're not going to change what's happening intracellularly with an exogenous amount of electrolytes in the bloodstream. So maybe we're referring to different things, but if you're referring to mitochondrial patterns in which neurons are close to threshold, I don't see any change with electrolyte supplementation for that. You might just be seeing positive changes because you're seeing actual electrolyte imbalances. Do you recommend any specific EMF meters or companies that sell EMF blocking products? I actually don't have a specific brand name. There's online sources people use. You can even get them off things like Amazon. They're pretty standard. I don't know if one is much better than the other. I would just encourage you to go to a source where you can read reviews and go from it, but I don't have any specific brand I can recommend. Is hair tissue mineral analysis not a quality assessment for checking heavy metals? What do you use? Yeah, so hair tissue mineral analysis is like the least reliable form of testing to really look at heavy metals. Heavy metals, can be assessed differently. If you're looking at levels in blood, then you're looking at acute exposure. There's some studies that show like acute heavy metal poisoning can show up in nails and hair. The only problem is with reproducibility of chronic toxic exposure. Do we really know what's happening, and if other things are contaminating the hair from exposure from the environment versus what's actually in the tissue, and how reliable the labs are in general? So the consensus for most people is it's the least effective way to measure chronic heavy metals. People use a challenge test, like a DMPS DMSA challenge, where they give them a chelator, do a baseline urine test, do a chelator, and do a post-test just to kind of see how much things they can bind with. Everyone's going to have some heavy metals with a challenge test. So the standard approach is to do like a DMPS DMSA challenge test, or there's even labs that do stool heavy metals. I'm not sure how reproducible that is, but the hair mineral analysis is just considered the least effective way. If you want to look at total body burden and how a chelating agent will work, then do a challenge test. If you want to see if there's any acute exposures into their system, then I would do like a serum test. you're going to be limited to the amount of things you can test with serum, just about what's available with labs. So I don't know if it's a good answer, but you're not going to have a lot of support by people with hair mineral, tissue mineral analysis for heavy metals because of so many studies that have shown poor reproducibility from one lab to the next, even within the same lab. Concerning sleep and circadian rhythm, do you think there's any credibility to the argument often presented by patients that they have a different circadian pattern that justifies going to bed hours after midnight and sleeping until late in the morning? Rationalization of real possibilities. Some people do better sleeping at nighttime. Some people work throughout nighttime and midnight, and then as long as they get the quality of sleep and as long as they're in a normal rhythm, there seems to be benefits in health. So it's that consistency of that schedule that matters. Some people can sleep during the day and wake up at night, and they get to that rhythm, and they just have continuous sleep and night cycles that maybe they're sleeping in the day and working at night, and their health is fine. So it doesn't really necessarily matter if it's one or the other, as long as that the rhythms are consistent. What is your experience with incorporating SPECT brain scans or genetic SNPs information in assessing and addressing mood disorders? The people that do SPECT brain scans, for example, at Amen Clinic or so forth, everyone has a problem. Everything's an issue. They get loaded with supplements. I'm not a big fan of that. The more conventional literature with SPECT scans shows some differences. All you can see is some differences. It's not specific for one thing or another. People make big assumptions. Genetic SNP information can be useful. Most of the SNPs have some mild effect. They're not going to be detrimental to disease, and many SNPs work in conjunction with each other. And the SNPs that we have available with it, like COMT is very useful. MTHFR can be useful and linked with some mood disorders and depression. But a lot of the other SNPs we're still learning much about. And I think it's with COMT and MTHFR SNPs that could be very useful. For the rest of the SNPs, I'm not sure if there's a lot of compelling evidence for it directly causing mood disorders. And I think the SPECT brain scans just show some abnormalities compared to other populations, but that's not specific for much of anything. I'm not a big fan of people getting SPECT scans and then ending up on 20 different supplements and 4 different antidepressants with the shotgun approaches, which I see happening in the healthcare system right now. Does anti-insulin antibody formed after traveler's diarrhea or C. difficile infection attack anything else other than enteric nervous system, anything in the brain or CNS? So technically, any type of immune response or antibody reaction may have impacts on the nervous system. Not every pathogen cross-reactivity pattern has been identified. So C. difficile has been associated, both types of antibody formations have been associated with central nervous system and inflammatory reactions. So it's very possible that they may impact the brain CNS. But with any type of cross-reactivity or pathogen-induced, and in this case would be nervous system injury, it varies from one person to the next, and we don't know what all the different variables are. Do you think DNA adducts from glyphosates may be why some patients do not improve despite interventions? How do you treat them? Others suggest IV phosphatidylcholine and colonics. It's hard to say. Glyphosate is just one of many toxic compounds that have detrimental effects on health. And there's people that have glyphosate exposure and can biotransfer them really no problem. Their phase 1, phase 2 biotransformation pathways are fine. And they don't have any immune reactivity to any kind of the changes in proteins or DNA that can be caused by glyphosates. There's going to be some people that are extremely sensitive to one chemical or another. So I don't think it's a general rule. And I'm not sure what IV phosphatidylcholine or colonics would do. What can people on the ketogenic diet do to stay asleep if they're well into ketosis but still having low glucose, low ketones at night? The best thing to do is just have them take exogenous ketones right before bedtime, or have something high in fat that doesn't cause them like a lot of bloating and distension to make them uncomfortable before sleep before they go to bed. They may need to include like another meal right before bed. So sometimes it could just be something like an avocado or half an avocado with some olive oil and some salt. As long as that doesn't cause bloating or distension with them, they can digest it. That could be a good way. And sometimes you just have to have them experiment with exogenous ketones, and they may have to figure out what dosage works best for them to stay asleep throughout the night. But just like people can get nocturnal hypoglycemia and wake up in the middle of the night, people can get nocturnal hypoketonemia when they're in ketosis and also wake up in the middle of the night as well. So the only reason you would have to, activate epinephrine, norepinephrine in the middle of the night to break down body fat for ketones if there's not enough ketones in the system. So if they can load up on ketones or have one fatty, dense meal right before bedtime, that could be helpful. And sometimes just making dinner closer to bedtime can be helpful. And sometimes it's adding another meal, and sometimes it's adding another meal before bedtime and also taking ketones. So those are the strategies I would incorporate. Since sleep is so crucial, does Ambien or other sleep meds alter the quality of sleep? And what do they recommend we use to help people get off these meds? So, ultimately when someone gets addicted to Ambien, which happens all the time, there's a change in their GABA receptors, like with all types of neurochemical modulating medications. And it may be very difficult to do that. There could be some degrees of withdrawal. So I would say you can have some degrees of withdrawal. Ultimately, patients can have to work with their prescribing physician to slowly back off over a period of time. The best thing I think you can do from a functional medicine approach is to support the resiliency pathway, make the resiliency as efficient as possible. So the resiliency pathways were, for example, make sure their circadian rhythms are healthy and ideal the best you can. Maybe sleep may be an issue, but when they try to go to bed and when they try to wake up and when they exercise, when they eat, that can be something that can be controlled. Blood sugar stability would be another key one, like that. Physical activity, exercise. All the things for resiliency we spoke about would be critical to optimize before trying to taper off the medication. How do you help someone fall asleep who has severe dizziness? The patient sleeps with the bed tilted up but gets dizzy and wakes up if she turns her head while sleeping. Has Hashimoto's been dizzy for 10 years? Crystals are not out. You got to treat the dizziness disorder. You got to figure out why the person has dizziness. If Hashimoto's, there's a possibility that they may have cerebellar autoimmunity. And obviously, the crystals are not out, meaning that you probably did a Dix-Hallpike maneuver and you didn't have any indication for BPPV. BPPV, the crystals are discharged, is very easy and clear to diagnose. You put someone in extension and rotation and you see nystagmus generate with that head position. It's possible it couldn't be a posterior canal that has a crystal in it. It could be horizontal or anterior, but the key thing would be head position of any, either to the side for horizontal or forward for anterior, or back and extension would cause nystagmus and immediate symptoms. If it's not crystals, and then you just look at someone with Hashimoto's, they just could have severe cerebellar autoimmunity. And with cerebellar autoimmunity, and it can also be there from gluten ataxia with Hashimoto's, they have the same genotype of gluten sensitivity. You've got to control their autoimmunity the best you can. Make sure that they're not going to bed in a hypoglycemic state, because if the brain doesn't have fuel, it can't dampen vestibular inputs very efficiently that are spontaneous. So that's really important. The most common thing you'll have to do with people that have like cerebellar degeneration is to do what are called gaze stability exercises. And gaze stability exercises, you just have a person fixate on a target and they slowly move their head back and forth in different directions. So we sometimes use the word yes, no, maybe, where they, do like no, yes, and then head tilts maybe. So they'll look at rotation, flexion, extension, and lateral tilts. Or you can have them stare at a target, just like do the alphabet with their nose, slowly. And they may just need to go into vestibular rehabilitation or work with some people that know how to rehabilitate their balance and vestibular system. But it has to be figured out. The most likely cause with Hashimoto's is either TPO cross-reactivity, which we talk about in detail in the Hashimoto's course, gluten ataxia, gluten cross-reactivity with the cerebellum as likely targets. There's also the possibility of GAD65 autoimmunity that happens with Hashimoto's people. GAD65 impacts the GABAergic pathways in the cerebellar Purkinje system that can dampen vestibular input. Is using a powdered green source sufficient if someone hates to eat veggies? No. Green sources and green powders will never substitute actual vegetables. Actual vegetables are rich in fiber. You can never get from a green source. How often do you see hyperprolactinemia associated with depression in patients who are not taking antidepressants? Meaning that depression causing hyperprolactinemia may be due to low dopamine. It's very, very rare. You're not going to see that often. I would say you may never even see it your whole career. It's possible, but it's pretty rare. For patients with debilitating anxiety about taking nutraceuticals or too depressed to move or eat well, they may need pharmaceuticals to get them to adhere to a treatment plan. To what extent will those pharmaceuticals be a barrier to making more permanent change in neurological pathways and changing the lifestyle and diet? For patients with debilitating anxiety, yeah, some people with severe anxiety absolutely need like anxiolytics to function, to activate the GABA receptors so they can get through it. Usually, I wouldn't think there's going to be permanent change significantly enough, like they become hopeless if they take anti-anxiety medication. So you kind of have to do what you need to do. Now, sometimes if they can work with natural GABA agonist things like valerian root or hops or kava kava, whatever's available in this country they live in, being used by the scope of practice of the practitioner, sometimes can be supportive, but there are definitely people that have debilitating anxiety that have to be on anxiolytic medication to function throughout the day. And then you really want to figure out what the cause of anxiety is. So we went through all the different neurological anatomical pathways that may be associated with it, and even some of the neurochemical issues that may be associated with it. You can at the very least support the resiliency pathways and see if that helps them lower the amount of dosage they need. But I don't think it's going to cause ongoing permanent damage if they have to use them. Do you find neurofeedback helpful in reducing neuroinflammation after concussion? The patient had 5 concussions during gymnastics in high school without losing consciousness, and 3 years later got anxiety and nausea associated with it. So I wouldn't say neurofeedback is good or bad. It's just another way to stimulate the brain, and different types of brain stimulating therapies may have both benefits and also make a patient worse. So sometimes you don't know until you trial and error. Neurofeedback definitely depends on some frontal lobe executive function integration. But anytime you activate the brain, you have the ability to dampen neuroinflammation. So neurological activation tends to promote an anti-inflammatory effect. As neurons get activated, they release growth factors and BDNF compounds, and they have a potential to dampen microglial activation, micropriming. And if the brain's not being active and being used, the glial cells that are surrounding it can assume that those neurons are unhealthy and can start to digest them. So neurofeedback can be very, very helpful to people with brain injury. Sometimes if their brain's really, really inflamed, they're not going to respond to any kind of therapy, whether it's neurofeedback or cognitive therapy or vestibular therapy or whatever the therapy may be, desensitization therapy. And sometimes you just have to get in there and use a functional medicine approach to dampen neuroinflammation, like support their leaky gut patterns, blood-brain barrier permeability, use natural flavonoids to dampen neuroinflammation, control their insulin, all the things we went into great detail with in the neuroinflammatory course. So those are the things to consider. Do you find neurofeedback helpful in reducing Okay, we did that one. How often are you having patients complete follow-up assessment forms after starting the treatment plan? 1 month, 2 month, 3 month. So my practice, every time I do a follow-up with the patient, I'll have them fill out their assessment forms. Now, I tend to do follow-ups initially once a month for the first 4 to 6 months until I get them on track and feel like they have things going. And then after that, I'll spread it to 2 or 3 months. But I typically have patients do the follow-up assessments. If you're following me tracking patients in the Clinical Mastery Training Program, you'll see that every month when we do a follow-up, there's paperwork with everything filled out again to see where things are. Next question. If St. John wort is efficacious as SSRIs and SSRIs are not very effective, then St. John wort is not very effective. Absolutely. You're going to have very limited effects with antidepressants, St. John's wort with most people. So the effect with it is not that great either way or the other. How do you differentiate the dysautonomia of POTS and TBI from dysautonomia of anxiety? Or is it a matter of prolonged unmanaged POTS, TBI, etc. that lead to anxiety? You're going to have to do a deep history and physical examination. POTS, you got to figure out what's causing the dysautonomia. If it's actually positional change, I definitely would think there's some type of neurological integration into those autonomic centers. One of the most likely causes of dysautonomia in POTS is traumatic brain injury with prime glial cells that have caught up with people. So, with people that have brain-related injuries and POTS with anxiety, usually motion and movement and stimulation to the brain can trigger their response. Like if you go take your finger and just move it around, or you have flashing screens and they start to get anxiety and symptoms, then you know there's some injured neurological pathways, that it's not just a neurochemical imbalance. Because you talk about your experience of supporting mood and psychiatric disorder patients between visits. Wonder if taking on patients with major depressive anxiety, bipolar, schizophrenia, or suicidal ideation would result in them phoning, emailing at all hours, needing immediate support they would receive from an ER urgent care. Yeah. I don't, first of all, in my practice, I don't work with anyone that has any suicidal tendencies. They're an immediate disqualification from my practice. So if I see, like, I don't work with cancer patients, and I don't work with any patients that have any kind of suicidal tendencies. I also don't work with patients that have any acute related issues. And we make that very clear with initial paperwork that we give to them. So we say, we're really here to help you with your diet, lifestyle, nutraceutical approaches to improve your health. We are not there to manage any kind of acute crisis. You need to work with your physician or other healthcare professionals to help you with any kind of acute issues. So I make it very clear from the very beginning. If you start jumping in on board with jumping into all these things and being the person that they jump into with all these things from a functional medicine approach, you're going to put yourself in an uncomfortable position. And if you see someone that has any kind of suicidal tendencies or schizophrenia, they definitely need to be working with a psychiatrist and have them on board for these types of situations. Major depression is not that big deal. Anxiety, sometimes people have flare-ups. What can you really do other than give them some instruction of anti-anxiety types of compounds, or exercising, moving, getting the heart rate up to deal with that. But again, it goes back to what's your role with your patient population in clearing and setting up clear boundaries. Okay, to mitigate the chance of mood disorders developing after one just experience, a TBI, do you recommend only resting, no therapies for 1 or 2 days, or them getting NUCC adjustment, NUCA adjustment, head ice, hyperbaric, arnica, craniosacral in the hours of the first few days post-incident, be advised to lower issues of downstream? Okay, so to mitigate the chances of mood disorders after one just, the question is not clearly written. To mitigate the chances of mood disorders developing after one just experience, a TBI. Listen, if someone gets a brain injury, you shouldn't be doing much to them other than letting them recover. Hyperbaric chamber would be the best thing. To go in there and immediately do an adjustment, you could actually, adjustments, whatever type of adjustments may be, soft tissue, light adjustments, heavy dose manipulations, touch even, is going to increase proprioceptive input. And depending on where the injury is, it could definitely make a person completely fatigued and exhausted. So I definitely would be very careful with any kind of stimulation or adjustment or any kind of physical modality, therapy, light, sound, movement, stretching, motion after any kind of brain injury. You really want to definitely consider things like hyperbaric. So hyperbaric oxygen therapy would be the ideal source after an acute traumatic brain injury. And that to be consistent the first 6 months to have continued care. Once you get past 6 to 8 months after brain injury, hyperbaric chambers don't have the same effect. So that in the acute phase, it can be very useful. And then anti-inflammatory compounds like fish oils, some studies even show like 10,000 milligrams, fish oils can be very helpful. Even things like progesterone, DHA have been shown in the literature to have some anti-inflammatory effects in the acute phase of a brain injury. And then even different botanicals that have anti-inflammatory properties like resveratrol, turmeric, glutathione, compounds can be supportive. I've read methylcobalamin and or methylfolate may be contraindicated for some who are double homozygous MTHFR, CMT, other methylation defects. Could you comment on those, please? Yeah, it's all made up. There's a whole field of functional nutrition medicine made up on MTHFR theories and protocols and total nonsense. So I would just ignore all of it. For what you've seen clinically, what mood disorders and cognitive challenges for what kind of cases do you find SPECT, PET, QEEG, and other tests useful in addition to in place of volumetric MRI? So, SPECT scan, again, like we answered earlier in part 1, they're being used in a general sense, like things like the Amen Clinic, where they're just looking at changes in function compared to other people. I've never seen anyone go to Amen Clinic and not have an abnormal SPECT. So I guess everyone in the world has something wrong, okay? PET scan, they're going to be used in research settings. QEEG, you definitely want to consider if someone has seizure activity, that'd be the best time for it. Volumetric MRI, if you actually think the volume of the brain is smaller, you're going to see that with mild cognitive impairment being the first use of it. And then brain MRI without contrast, usually if you're just trying to get a general screen, if there's any kind of pathology or injury to the brain, you're going to do an MRI without contrast. So those would be the situations clinically for those. The patient with a mood disorder has a history of transient ischemic attacks. Other than supplementation that helps overall circulation, nitric oxide, what can we offer them to heal those areas affected by TIAs? So again, hyperbaric chambers can be useful for any kind of brain injury, including transient ischemic attacks, especially in acute stages. That'd be one of the most powerful things you can do. Anything you can do to dampen neuroinflammation is always a good idea. All the different flavonoids that have neuroanti-inflammatory properties, green tea extract, apigenin, luteolin, green resveratrol, curcumin, they can be very supportive for that as well. And then movement and activation of areas of the brain that are injured slowly, that don't exceed their fatigue rates, can be very helpful for recovery as well. When their mental status is so poor that they're not able to or willing to complete any intake forms before they arrive at their initial consult and don't have a partner or caretaker to fill them, how would you proceed differently in terms of process flow that first appointment? We personally don't work with patients like that. So we don't even schedule an appointment until they get all their paperwork in. So we don't even put them in the books until we get all the paperwork in. And we have some patients with severe cognitive impairment that sometimes take 2 to 3 months to fill out all our paperwork. I mean, I basically work at the situation of, I put myself in the circumstances. I need certain piece of information to help me do a right job. So, I would encourage you to do the same. If don't schedule someone until they have all their intake forms and everything completed, before the initial consultation. To me, I absolutely need it. It saves me a lot of time. I can be very fine-tuned. Every single patient I see is critical for me. Like I can't let things that I need diagnostically not be done. So I don't care if it takes someone 3 hours to fill out a questionnaire form over the next 2 weeks. Once they fill it out, it can be useful. Now, if you do see serious issues with some people, you may need to maybe say, okay, well, maybe you need all the forms. You need some of these forms. But I found also that there's a point where people don't have the ability to respond. Like if they can't communicate well to you, you're not going to have a really good time improving their case. It's just that simple. One of the things that we need in a individualized, personalized medicine approach is the ability to communicate back and forth of what's working and not working, and trial and error, working through the process. So that would be one of the things I would say. And more importantly, it would be a red flag to me that they're just copying out. When you see the best patients are the ones that will get whatever needs to be done to get better. The ones that just say the mental status is so poor they're not able to do it. Maybe they have someone read the questions to them, fill it out, but they figure out how to do it. So it could also be a red flag for you. When clearing extremely high chemical loads found in MTHFR C66T patients, what are the most important things to keep in mind? When most classes of chemicals are off the charts high in GPL tox, what types of IV and supplement combos tend to bind to many of them chemicals that complement one another effectively? So if someone has a methylation defect, then you bypass their defect and give them methylfolate or other substances. There's nothing that's been more manipulated into various crazy theories than methylation MTHFR pathways in the world of nutrition and functional medicine. if most chemicals are off the chart, you would suspect that they may have some biotransformation issues. And methylation is only one pathway where toxic chemicals get cleared out. So there's glutathione conjugation, acetylation, sulfation, right? Methylation is just one of the pathways that certain chemicals are cleared out through. So if someone has methylation defect, it wouldn't explain every single chemical not being able to be metabolized. So it would either have you associated with exposure or a lot of buildup in their body fat and tissues itself. But I don't think it would tell me other than I may need to support methylation pathways. And if I really thought they had a significant methylation defect, I'd want to look at the expression of that by looking at their homocysteine levels. Because if you're not methylating, then one of the things you can't do is convert homocysteine to cysteine and see what those levels are. There are a lot of people that have genetic SNPs, but they don't have phenotypic expressions of those SNPs. So, many people you're going to check are going to have MTHFR polymorphisms, but not all of them are going to have methylation defects because they still have enough folate and B12 to have biochemical mechanisms happen. Okay. A patient with a mood disorder has high amounts of fungal expressions, tinea versicolor, over large areas of their body. How do you prevent the die-off from making it through a leaky blood-brain barrier? Well, first of all, if you have fungal expressions that are on the skin, it doesn't mean that it's in the body systemically and in the bloodstream and it's going to get to the brain. So you could just have a local, topical expression, first of all. With any, if you're worried about the blood-brain barrier, test it and make sure you heal it. You can heal the blood-brain barrier pretty quickly. Make sure the gut barrier is healthy, and then, basically anti-inflammatory compounds, things that impact blood flow to the brain, which we went over in detail in the course, can all be used to try to help that integrity. It doesn't, really change anything. With a very thin and weak patients who have a long history of anorexia and bulimia impacting their brain, what strategies and products do you find most helpful in building their body and brains back up, other than fatty foods and oils? Well, protein. You've got to get these patients on protein. So if someone has anorexia, doesn't have muscle mass, you got to get them on protein. That's the most important thing. So proteins and healthy fats. You have to have essential fatty acids, and you have to have protein. And they have to consume that at enough of a caloric intake to actually change their muscle mass dynamics. And you may not be able to get far with them unless their underlying psychological patterns associated with things like bulimia or anorexia are managed. But ultimately, protein and healthy fats are the most essential things. Patient that's been on many medications, what kind of drugs permanently damage receptors and receptor sites, and how do we support them? You don't know. How do you clinically know if a receptor site's been damaged? You don't. There's no way to test for it. We don't know if anything is, there's receptor sites that can change their expression, but also remember that receptor sites regenerate after so many weeks, after so many months, that the brain is constantly changing. Receptor sites are constantly changing. Sometimes they're downregulated, sometimes they're upregulated. I don't know of permanent damage to receptors long term, because these tissues are in constant dynamics of being regenerated and dying off. There are some studies that show some altered signaling that can happen for a period of time, but I don't know what I call that damage. And any other things in life, and chemicals, different exposures can cause those different receptor site expressions. So to answer your question, you would never know. There's no way to test, and it's really unlikely that there's ongoing permanent damage to receptors. There could be changes in expression of it for periods of time, but lifelong, forever, I don't think it's likely. The brain is very dynamic. It's very plastic. It can change. You can have half the brain taken out, and still have other parts of the brain compensated. Well, in early ages, while the brain's still developing connectivity and plasticity. But we're developing connectivity and plasticity through our whole life. So there's a lot of flexibility in neurological pathways, including receptor site functions. I'm finding more and more patients testing positive for antibodies to corn. How have you found this to be in your practice? Can you speak to any differences in the body for those who are sensitive? Yeah, corn is definitely one of the most reactive proteins out there. So I think it's gluten is the most sensitive. Then gluten and dairy are way up there. Soy, egg protein, like egg albumin, and corn. Those are the most common. So, can you speak to any sort of difference in the body for those who are sensitive? I'm not sure what you're asking the question, but can you speak to any similar differences in the body for those who are sensitive? It's just one of the most common. It's the most common proteins. There's definitely some associations between, soy and corn both being GMOs and being very highly reactive with people. Maybe the GMO modification has impacted the proteins, so we see more of it in clinical practice than other proteins. But in any case, I do see it very commonly, and I think that's what you're asking. I don't know how to answer your question about similar differences in the body for those who are sensitive. I think it's just a very common one you're going to see with lots of people. Okay, I did my best trying to answer your questions. Thank you for submitting them, and I hope you found it useful.